Dear chairs, dear colleagues, I would like to present my PhD topic, the novel treatment approaches in penile cancer. My name is Judit Vargha. I'm a trained urologist and andrologist. I work at Semmelweis University in the Department of Urology. My mission is to search for a more effective treatment for penile cancer patients and thus prolong their survival and improve their life expectancy. We have three topics related to penile cancer. The first two about the immune checkpoint inhibitor therapy. The first one is a meta-analysis. The second one is an international survey. Whereas the third is a socio-economical topic about penile cancer. This is a registry analysis. My first topic is comparing efficacy and safety of immunotherapy with chemotherapy in penile cancer patients. As a background, I would like to highlight that penile cancer is a very real and very aggressive malignancy. The average incidence is low, but it's notably higher in underdeveloped countries. Unfortunately, most of patients seek medical advice late when the tumor is already in advanced stage. And for these patients, the first-line treatment after surgery is chemotherapy. But even despite chemotherapy, the 5-year survival only 16%. Most penile cancer has squamous cell carcinoma, and they have a very high PD-L1 expression. The penile cancer have a very similar with skin squamous cell carcinoma, and in dermatology, they use immune checkpoint inhibitor therapy as a first-line treatment for several years with very good efficacy and safety, but there's a lack of evidence to use immune checkpoint inhibitor therapy in urology. So we aim to investigate the effectiveness of immunotherapy in penile cancer. Our clinical question was, is immunotherapy more effective and safer than chemotherapy in penile cancer patients? In penile cancer patients, we investigate the efficacy and safety of immunotherapy versus chemotherapy, and our hypothesis is immunotherapy is more effective and safer compared to chemotherapy, and our clinical implication would be to introduce immunotherapy into daily practice in penile cancer patients to improve quality of life and prolong their survival. We found more than 4,000 articles in 3 main databases with our search key, which first domain contains the disease, penile cancer, whereas the second domain contains immune checkpoint inhibitor therapy and chemotherapy. After the selection process, we found 58 articles, and it was very interesting because we didn't find any article which compared immune checkpoint inhibitor therapy with chemotherapy within the same article. So we decided to collect chemotherapy results and immune checkpoint inhibitor results in different data collection sheets, and after we indirectly compared that. Our first result was overall survival in immune checkpoint inhibitor therapy, and as you can see, there's a very huge difference between our studies. The upper two study with better survival rates use immune checkpoint inhibitor therapy as a first line, whereas the other 3 study use it as further line therapy. So we decide we do subgroups, first line immune checkpoint inhibitor therapy and further line therapies. Our results with overall survival, we check it at 6, 12, and 18 months. Our second result was progression-free survival. We see the same difference between the first line and further line studies, and we check the progression-free survival at 3, 6, and 9 months. After 9 months, there were very few patients, so we can make analysis after 9 months to progression-free survival. And in the end, we make the indirect comparison between chemotherapy and immune checkpoint inhibitor therapy. And as you can see, there's nearly the same survival times. But I would like to highlight that chemotherapy, these articles, every article uses chemotherapy as a first-line treatment, and immune checkpoint inhibitor therapy, there is further line treatment. So these patients in the immune checkpoint inhibitor arm, they get immune checkpoint inhibitor therapy after failed with chemotherapy. So it shows this is a good therapy and effective treatment. And we can pull together the first-line therapies, but if we check these two articles, there's a very, very good survival rates. Summarizing our results, with overall survival, with first-line chemotherapy and further-line immune checkpoint inhibitor therapy, we have the same survival times, whereas with first-line immune checkpoint inhibitor therapy, it's much better. This is the same with progression-free survival, and with subgroup analysis, the results show us with HPV positivity and PDL positivity, the patients have better chance to survive. So the limitations of our study, we use only single-arm retrospective studies, case series, case reports. We have a very limited number of patients with very heterogeneous patients population, tumor stage, previous treatment, and treatment protocols. The strengths of our study, this is the first systematic review and meta-analysis in the topic. Individual patients that are included in the analysis, and this is the largest patients population to date to evaluating the efficacy and safety of immune checkpoint inhibitor therapy. We conclude that immune therapy for advanced or metastatic penile cancer is an effective and safe treatment, or we recommend to use it as a first-line treatment, especially combined with chemotherapy. And our implication for research, we need more study with direct comparison between immune checkpoint inhibitor and chemotherapy, and we need to investigate the prognostic factors and markers to decide which patients' populations benefit from this treatment. We finished the article, we sent it to language editing in this Monday. Our second topic, to investigate the effectiveness and safety of penile cancer immunotherapy versus chemotherapy, the PICNIC study. This is an international survey. The background is the same with our first topic, and our implication for research in the end of our first topic was we need more study with direct comparison between immunotherapy and chemotherapy. So we decided to collect in patients data where they have first-line immune checkpoint inhibitor and chemotherapy. And we finished, our PICO framework is the same. And for clinical implication, we would like to introduce immunotherapy as a first-line treatment for penile cancer patients. We finished the study protocol and questionnaire. This is a retrospective data collection from September 2018, when FDA approved the immune checkpoint inhibitor therapy for skin squamous cell carcinoma. We sent the questionnaire to centers who are treating penile cancer patients. We have two data collection sheets, one for chemotherapy and one for immunotherapy. And in the end, we planning to make a comprehensive matching analysis. So we finished the pilot phase, and we now waiting for the data from the co-investigators. Our third topic, to investigate the reasons for prolonged denial in patients with penile cancer. This is a registry analysis. As I mentioned, penile cancer is a very real disease, and most of patients seek medical advice late when the tumor is in advanced stage. And there's very few mention in the literature. These patients have a low socio-economic background and lower level of education. And we have a registry in our department, approximately with 200 patients' data. And we would like to identify the high-risk patients based on their social circumstances. So, summarizing our topics, the first one we would like to submit in this month, and we would like to finish the second and third in the end of this year. And I would like to thank you for your attention with a quote from Terry Pratchett. It doesn't stop being magic just because you know how it works. Thank you.
Thank you for your presentation. I would ask regarding to your first project, do you plan compare the different immunotherapeutic agents?
Yes, no, we can't because we have a very few patients, nearly 100 patients with immune checkpoint inhibitor therapy, and in every center they use different type of therapy. The most common is cemiplimab or pembrolizumab, but they use every kind of immune checkpoint inhibitor, so we can't do this analysis.
Thank you.
Congratulations for your very interesting presentation. The chemotherapy and the immunotherapy, that is a neoadjuvant or just adjuvant therapy?
Yes, in our topic we just collected the adjuvant
Just
therapy.
adjuvant?
Yes.
Okay, thank you.
Thank you for the presentation. It was really impressive. And my question would be to the first project. So the immunotherapy is the third-line therapy. Are there relevant concerns with the immunotherapy, or is it just a financial question?
No, in the European urology guideline, they mention immune checkpoint inhibitor therapy, but there's no enough evidence. It's just mentioned, and they told us it's promising therapy, but we need more studies. As the financial one, immune checkpoint inhibitor therapy is 3 or 4 times expensive. But if we ask permission from the government, we can give immune checkpoint inhibitor therapy to our patients.